Discussing transforming the outpatients operating model using digital communication, please welcome to stage our speakers and session chair Jacob Haddad.
Right, good people, can you hear me? Yeah. That was the least reaffirming yes I've ever had. Can you hear me? Yeah. Hoorah, right, pre-lunch session, bit of energy in the room. So, welcome. For those of you who don't know me, my name is David Sloman. It's my privilege to chair the session today. I should immediately begin by saying, although it was programmed that Andrew Wilkinson was due to join us, unfortunately, in many, many ways, he's been held back at Guy's and St Thomas's helping deal with the cyber security attack which has so profoundly affected service in South East London. But nonetheless, we have outstanding talent on the stage to work through how we are going to transform outpatients into the future. Those of you who don't know me, my name is David Sloman, and last September, after 40 years in the NHS, I retired, and I was reflecting today that the outpatient department I walked past in 2023 did not look enormously dissimilar from the outpatient department I walked past in 1983 when I joined the NHS. Put your hands up if you use NHS outpatient services as a patient. Yeah, do they look pretty much the same now as they did 10 years ago? They do, don't they? Yeah, so nothing else looks the same as it did 40 years ago. So if the recent data actually, survey by the Royal College of Physicians said that 25% of doctors say that 10 to 20% of all their patients didn't need to come in to have an outpatient appointment at all. 28% of doctors said that 10 to 20% of their follow-up appointments could have been seen using an alternative, non-face-to-face consultation. And 57% of outpatient clinics finished late either every day or at least once a week. Have any of you had that experience of a late outpatient appointment in an NHS hospital? In fact, I should say, have any of you had an experience of an on-time outpatient appointment in an NHS hospital? I have got some, as I say, really interesting and outstanding people to join me today with this conversation who will now introduce themselves before I open the questions. We've only got half an hour. I'm going to ask a few loosening questions. If you have questions, start thinking about them. Be ready to put your hand up. We'll try and find some time to take some questions from the forum. So, Hal, could you tell us who you are? Tell these good people who you are and what you do.
Yeah, so I'm Hal Brindley. I'm a consultant hepatologist and gastroenterologist at Barts Health, and I have a particular interest in trying to develop and change our services for the benefit of our patients. And my views, of course, are just my own, not in representing the trust today.
Okay, and Jacob.
Jacob Haddad, CEO and co-founder of Accurix, and we're a communication platform for healthcare. So lots of you use us, you may not realize it, but use us when you communicate with your GP, when you get in touch with them, when you send a message. But a lot of what we're working on now is solving that same communication challenge in secondary care, and particularly what we'll talk about today is to modernize outpatients and the way it's delivered.
Okay, thank you, Beth. Right, so to get the ball rolling, can I start with you, Hose? If you had a blank slate and you were starting again, you know, what would your outpatient department function, what would outpatients look like?
So, I mean, I think we know that, as you're saying, this model's been in place for some time, that we end up this transfer of information, a data dump from our primary care colleagues, of course, who are under sort of great pressure to sort of deliver sort of their outcomes from their outpatient, from their consultation in a short space of time. So we're receiving these large amounts of information as a 30, 40 page PDF, where the key bit of information is hidden on page 26 and a half. And it's about, then we're offering this poor individual potentially a slot for an appointment many months in advance. And it's really working out how we can change this pathway and get the right information from our primary care colleagues, but also then giving the right information to the patients and getting the right investigations and tests organised for them in a timely fashion. And it's whether that even needs to take format of an appointment in the first place. And I think what we really need is that ability to be able to look at those information in a virtual setting in advance without having the physical need for patients to sort of attend in person to a hospital. Identifying what they might need already to be able to have a sensible and useful conversation with the patient with the appropriate results and tests in front of both of us.
So, and how far away do you think we are from that at the moment?
I don't think it's a massive leap forward. I think realistically it's about changing the way we're using the time of our clinicians, whether that's your allied health professionals, your consultants. It's working it into people's job plans and about allocating time, sort of enhanced sort of vetting of referrals, that you are starting that process and that dialogue from that initial contact from your primary care colleagues. It's at that point in time, if we have that appropriately resourced in terms of person time, and I said it doesn't necessarily have to be a consultant, it can also be some of our allied health professionals, identifying and gathering additional information from patients using certain platforms and resources, through the form of maybe questionnaires about symptoms and things, but also arranging those baseline investigations which most specialties want to organise for certain presentations.
Okay, we'll come back later from how you get from where we are to where we need to be, and also what that means from a patient perspective as well as the staff perspective. But Jacob, can we hear from you? If you know, share the future. What does it look like? Good outpatient departments into the future.
So the biggest overall shift will come from when we move away from seeing appointments as the only way that healthcare is delivered. Everything has to be an appointment. Appointments go in an appointment book, one after the other, for lots of reasons. But the biggest is it's impossible to get productivity gains on a half-an-hour appointment. A half-an-hour appointment took half an hour of a clinician's time 40 years ago, and a half-an-hour appointment takes half an hour today. Now, to actually do that, okay, how do we move away from appointments? How then is care delivered? A few things need to happen. The first is we've seen in general practices moving up to 40% of what would have been appointments and doing that through messaging. And we see innovative clinicians starting to do that, but secondary care is where general practice was about 6 or 7 years ago, where really
40% you said there.
Up to 40%. And there's a distribution, some it's much lower, but a lot of things that the most obvious examples are things like normal test results that previously would have been an appointment, but actually clinicians doing much more advanced clinical practice through messaging. So that's one area. The second area is really rethinking how we do follow-up. Every time I speak to a consultant, often the thing that frustrates them is see a patient, no change, see again in 6 months. And imagine if your GP practice did that and they said, all right, we've seen you, you're fine, we'll see you again in 6 months. If you don't need it, whatever you do, don't DNA. If you do need it sooner, you can call us, but we might not be able to pick up. You can go to A&E. Practice would collapse. And so we have to empower patients to get in touch when they need specialist care. Now, the obvious concern is how do we manage demand and the floodgates? But if we take away all of those follow-ups that are just booked in on that, every 3 months, every 6 months, that creates a huge amount of capacity. And then the third piece we've seen have a huge impact is making sure when you do see a patient, they have all the right tests, all the right blood tests, all the right imaging. If you need to collect information from them before, like you mentioned the questionnaires, that's been done. So you go into an appointment really informed. Because if you have an appointment and the only outcome is, right, we're going to order these tests and then we'll have another appointment to discuss them, that's twice as many appointments as it could have needed, which is an issue for productivity, but patients also don't want to be coming to hospital unnecessarily. They've got to schedule that, they've got to get there. So those are the three big levers we've seen, but that does require a big shift in how services are run.
And can I ask, as you mentioned at the beginning, I think Accurex is in about 98% of GP practices now across the UK. What's it meant in terms of the management of change process, working with those practices about? Because often it's not about the technology, actually, it's how you change the work processes and the workflow. So what's been the challenge there, and how analogous do you think the change processes in the acute sector will be as we move into that direction?
So I sometimes say to the team that the tech is the easy bit. It's not to say it's easy, but relative to actually changing how services are delivered, services that have been doing this, running in a similar way for 40 years is particularly challenging. What led a lot of that in general practice was innovative clinicians saying, I can think of a better way to manage this patient. Actually, I don't need to bring them in. And doing that, often individually, and then that spreads within the practice. It might be one of the partners, it might be one of the salaries, and then that spreads. That spread is a lot harder in acute hospitals. That even initial innovation is often harder. It's hard, for example, to say, right, I'm going to go and instead of seeing these 10 patients in person, I'm actually going to send them, resolve this through messaging. If my clinic template doesn't have time for me to do that, or if the patient automatically gets sent a letter to say, come in on this date and time. And so there are a lot more moving parts in the trust. And as everyone here, I'm sure, feels on a regular basis, like there are all the fires, there are all the other challenges, and these changes take a lot of headspace. They take a lot of leadership, a lot of headspace.
Okay. What's your take about how this would work its way through in the hospital?
I think it's about being able to demonstrate the benefit, isn't it, to each individual clinician, how they think it can change their work, that they work in a more effective way, and actually offsetting other things, because actually a lot of services obviously don't have, are only able to offer their next appointment in X number of months' time. That blood test, that scan result comes back in 4-6 weeks' time. I personally don't feel it's appropriate to let people wait for months and months on end without having that information fed back to them. Some clinicians do that through sending letters, which obviously then requires them either dictation or typing them in, and then going through another system, and then being rechecked, and there's all these other sort of levels to things. But if we can integrate sort of messaging processes that are far more fluid and contact patients, as I said, it really can reduce the amount of administrative time related to passing that important information back to patients. I think also it's about demonstrating how it can save time. I think being able to have that sense of communication with patients and giving them the information when it comes to you means that it's reducing the number of times patients are trying themselves to try and contact the administrative staff, sending emails, leaving messages, and then secretarial and administrative staff sending those then on to consultants. So I think it then does have an impact in improving time. But I think I quite often will say, well, okay, I'm not going to physically see you for 6 months. I know, because I do not have the capacity to see you for 6 months. But before then, I'm going to arrange this, and this, and I'm going to tell you about this, and this. And if there's questions about there, here is the direct phone number for my secretary. Here's the direct email address for our team. Come back, and I send in the clinic, whilst I'm sat with the patient, I send them a message. Here is the email address. Here is the phone number. If you don't get the letter, if you don't get the scan, this is how you get in touch with us.
So that's really interesting, because one of the things you often hear when we look at transforming these elements of the system is actually patients like going to the hospital to see their doctor. I know we've heard, oh no, they don't. But I know some people, oh yes, they do. And the other thing you hear is that some of the clinicians actually like the patient to be seen every 6 months or so. How do you deal with that? How do you negotiate that with the patients? And I'm going to come see how we've negotiated that in general practice, actually. How have you managed that process? Go on, Hal.
You start.
So I'll start with the clinicians, but I won't speak for you, Hal. I had a really interesting conversation with a gastroenterologist the other week, saying, I want to see these patients every 3 months, and we were digging into why and okay, what do they clinically need, and what it boiled down to, and they said this is really, I want to see them every 3 months because if I don't have trust in the systems, and that they will have had this scan that they need, and that they would have had this test result, and that they, if symptoms have got worse, that they would have been able to get in touch about it. And seeing them every 3 months is essentially a safety net.
But coming off that, I would have to say your safety net needs to be another process. It's having a process whereby you can set up reminders that come up to you and say, has this, I'm looking for this result, or alternatively, you automatically decide that you want to send out a symptom questionnaire to your patient base every 3 months, and it's automated, and it comes back, and if there's a high score or a red flag, then it's highlighted to you. So these are the sort of tools that enable that, but also building in things, I imagine, when it comes to things like gastroenterology, inflammatory bowel disease, as part of that standard sort of disease activity questionnaires, it's sort of things thinking about, what's your current weight? Have you measured it? Put it into this box so we know what's happening, and you're able to track these data and these important metrics, which then flags up people. It's kind of add on to this concept of PIFU, and it works obviously for certain conditions, not others. I obviously run hepatology clinics. I would say 90% of my patients do not have symptoms related to their underlying condition. That in itself has various impact. It means that they're much more likely to be disengaged in care. They don't quite have the same level of understanding of the need to come to an appointment or be engaged in tests. When you've got a symptom like significant diarrhea or pain, that's obviously a very significant driving factor for being engaged and wanting to solve your problem and improve your disease. So there's obviously, it very much depends on the disease space, but you can build in through those processes that aspect to provide that regular input. If you can automate it, the fact that you're not then reliant on a booking clerk or the printer spitting out the letter or these sort of factors.
Okay.
Yeah. And to your question of as do patients want to see a clinician? I mean, sometimes they do, and sometimes they don't. My personal experience as a patient under 2 outpatient specialties in the same hospital, one of those specialties, I'm brought in, sent an appointment it was 3 months now, managed to get it to 6 months, that I never need. It's a very, very stable condition, and it's impossible to cancel, so I have this like moral dilemma of, is it worse to go to an appointment I know I don't need, or DNA an appointment I know I don't need, and I don't know the answer if you can't cancel it. And another specialty, so I have IBD where I have an email address for the CNSs, and very rarely have an appointment, and everything works through there. And actually it's quite inconvenient going in for an appointment just to say, right, can we order these tests and issue this prescription? I'd much rather just do that through messaging. So individual patients will vary, but I also think at different times in their life, in their the progression of their condition, they might want an appointment or not. There are definitely times when I do want an appointment, I do want to speak to someone. But if it's just arranging tests and changing prescriptions, often I don't.
Okay, so I can just about see into the audience. If people have got a question, can you raise your hand so we can start to think of running the mic around, please, as I cover my eyes. Before we do that, I've just a couple of, there's a hand up over here, actually. Can I ask you a really boring question, Jacob? So somebody came up to me in the foyer 10 minutes ago and said, what exactly is asynchronatic communication? Because everybody's talking about this. What is it? Asynchronous communication.
Asynchronous communication. Essentially it's messaging. So synchronous, both parties, patient and clinician, need to be available there and then. Now that could be face to face, that could be over the phone. Occasionally it's things like video, but both people have to be available at the same time. Asynchronous communication is essentially messaging. So I can send Hal a message now, even if he's with another patient or he's not at work today, and he can look at it when he gets to it, which then opens up a lot of opportunities. So maybe Hal's not at work and it can be assigned to one of his colleagues, or maybe Hal's had a lot of demand today and it can be assigned to the right place. When things are messaging, it's a lot easier to have templates, which then actually you're starting to automate a lot of your work, because you're not, in an appointment you might be going through asking me about all these different symptoms, whereas actually if you, for example, have a templated questionnaire, you can send that out in a couple of clicks, and what would have been, say, five minutes of the appointment has taken you 20 seconds or less.
So that's the key. Okay, can I have the question, please?
Hi, yeah. Oh, God, sorry. I'm Olivia. I'm from SHS Partners, which is an insourcing organisation. You spoke a lot about the follow-up appointments and how you cascade information to your patients without seeing them physically. But what about the waiting list to actually get to that new appointment? What's kind of the idea around how we ensure that's quicker or more efficient than it currently is?
So I missed a bit. What quicker did you say?
So for that first initial appointment, you spoke a lot about the follow-ups, but what about that initial appointment where people are waiting so long for?
Yeah. So I think the question is in the context particularly of the waiting list challenge that we collectively had, how does this come to bring to bear in terms of first as well as follow-ups?
Well, I think what it is actually some patients may not need that first follow-up appointment, that first appointment, that enlarged, longer appointment. It's making sure that you front-load that information and saying, I've seen this referral, I think you need these tests, I've requested them, is that okay, can you attend for them? Then it's coming back, I've had these results. This is not okay, that's okay, but that can actually be potentially done with either in a shortened follow-up appointment rather than a new patient appointment. So you're automatically increasing your capacity by saying that actually most of these patients, maybe I don't know what proportion, but could actually be only seen in a follow-up slot, which is shorter than a new appointment because you've gained the right information prior to that first interaction where you speak to the individual, whether it's telephone or whether it's face-to-face.
And the other thing I'd add is we can flex templates. So if as a system we can take out 25% of the follow-up activity, that can be turned into new appointments to get through the waiting list.
And actually, Joe, how does the Accurex help in general practice with people wanting to make a fresh appointment to see a GP? How does that work in that context?
So 5 years ago, 5, 6, 7 years ago, if you wanted help from your GP practice, you called up and you got an appointment. And the big shift that's happened over the last few years is that you get in touch and you are triaged. And that might be the request is assigned to one of the allied health professionals. Maybe it's a physio, maybe it's a nurse practitioner, maybe it's a pharmacist. That might be, say, oh, actually, before we see you, you need to do these tests. That might be, oh, actually, you don't even need an appointment. We'll just send that referral to you or whatever it is. Now, we've got to be really, really careful with PIFU, because PIFU is a brilliant, brilliant concept, but it's very easy to implement not very well and not see the benefits. Because if we're saying to patients, we're going to put you on PIFU, get in touch when you need an appointment, you'll get an appointment, we're missing all the benefits. And what we're sort of reinventing for outpatients what general practice had 10 years ago and has now moved away from. The way to do things like PIFU properly is say, when you need clinical advice or an intervention, get in touch and we will triage it. And that might be you need an appointment, but that might be we'll order some tests first, or that might be, right, we can just adjust your medication and send that back over. So it's really important we don't lose that learning and just turn everything that comes through PIFU into appointments.
Okay, helpful. Right, are there any other questions? There's a question at the back, please. I can see one on the left there, that's right, and one at the back. Yes, please.
Thanks. I'm Frankie Swords. I'm a hospital consultant as well as an ICB CMO. It's not all or none, is it? So I'm quite a keen adopter, and I brought in sort of vetting of referrals and pre-clinic investigations, years ago. And when you then see them in clinic, obviously on a new patient appointment, you get to discharge people on the day a lot. I haven't taken the leap to sort of discharging them before they've come, because that's sort of the anxiety about wanting to physically, see them and assess them. But similarly with PIFU, there are sort of different ways of skinning the cat, aren't there? I use PIFU a lot. But I also use sort of extended PIFU, where you say, get in touch, and we use an app. So they use Doctor in my hospital, in fact. And so they'll get in touch if they think they need to be seen, and I'll say, actually, your bloods are fine, or yes, actually, I will see you. But you can also safety net and give them a sort of a 3-year safety net appointment so they don't get lost, because there's a lot of anxiety that people will disappear. So that's just a sort of comment, really. And my question is, in primary care, if you do message, it's captured, isn't it? Because that's the big thing. I will do 30 or 40 letters every day I work clinically with the scan results and the blood results. And I'll often ring first so the patient knows, but I have to have it documented somewhere. And so is Accurex integrated into EPRs? Can you get it so that it's captured? Because I feel that anxiety that I know I've told them, but their GP doesn't know I've told them unless I do a letter to the patient copying the GP.
Okay, thank you. Very helpful comment and a helpful question, Jacob.
Yeah, so everything needs to be captioned and documented. We can integrate with any EHR. Obviously, it depends on what system the trust is using and where they're up to. In terms of the piece around this extended PIFU, I think that's exactly, I mean, like your point, it will depend on the condition and how much of that is symptomatic and how much of that, the patients, we can rely on the patients and how much of that requires monitoring. But even monitoring often doesn't take appointments, it takes the diagnostics. But some of the big successes we've seen are keeping the diagnostics in, taking out the appointments, because if you're coming in every, at Leicester, in thoracics, they had patients who'd had lung cancer, were coming every 3 months for a CT scan and then an appointment 2 weeks later. And we thought, okay, right, the easy benefit here is instead of an appointment, the vast majority of the time those scans are clear, that saves all the appointments giving out results. We didn't expect the benefit of these patients saying, well, actually, I was waiting 2 weeks to find out if my cancer had come back or not. Every 3 months, it's like eight weeks of the year they're waiting, and normally it hasn't. And so they're making this communication faster also benefits patients a lot. But the risk part around PIF is I find very interesting, because instinctively people get to okay, well, let's put the lowest risk patients on it. Sometimes even the ones who might have been discharged, and that can be a problem in some cases. But actually, sometimes it's the highest risk patients who you need to be able to get in touch really easily, rather than, as humans, we don't get sick on like 3-month and 6-month schedules. Aside from the fact that there's so much risk sitting on the waiting lists, and we've got to make it easier for patients to get care when they need it, essentially.
Okay, thank you. So we've probably got time for one more question. I think there's a hand on the left. I think the answer, yes, it will link in and record, is the key thing now. So, yeah, final question. We've got a few more minutes.
Yeah, hi, I'm Christian. I'm head of elective care for Gloucestershire ICB. Bit of an echo. One of the largest drivers for clinical change, behaviour change, etc., will be financial flow. So, face-to-face appointments gain a tariff, non-face-to-face gain a tariff. What we're describing here has no mechanism for capture, quantification, or payment. If you were to pay for it, everybody would change very much more quickly than the advocates we've got on the stage, because the managers would have a mechanism to resource it and fund it and so on. And if you want to make this work well for clinicians, they don't even need to go to the hospital to do it. And they will do a heck of a lot more of it at home in an evening on a Saturday, when they can just fit it into their life, if indeed there was a payment mechanism that could reward that. So you want to make more out of your staff and give them a work-life balance. Dragging consultants to the hospital every week to sit in clinics whilst people line up outside, we've all agreed is old. But money will be one way to stimulate that change.
So can I say that is such a fantastic question to ask, with 2 minutes, 38 seconds to go, of how do you reform the whole of the NHS payment systems? So I am going to say one thing around that personally. That is why ICBs have been established, to look at how you collectively use money in the round in the best interest of the patients, and you should be thinking locally and flexibly about how you do that. 2 minutes to go. Last word from Jacob. I'm going to allow you to finish, Hal. Jacob, if you were to say to people, this is what you need to be thinking about in terms of how you reflect on moving from where you are to where you need to be with outpatients, what would you be advising the management and the leadership to be thinking about?
So it would be, first you need you need some headspace.
Yeah, you do.
And then it's, okay, let's, with our specialties, work out where are the appointments that we can free up, where's capacity we can free up. And the ways we've seen that done are making sure triage is right of referrals coming in, making sure that we're only doing follow-ups with the patients who clinically need it, rather than just booking it in. Asking clinicians, getting them to go through their, the clinics they've got coming up, and right, who are the patients here where we don't actually need to see them, we can resolve through messaging. And then for everyone who is coming in, what are all the tests we know we're going to need, so that that encounter isn't wasted, and it doesn't have to be repeated once those results are in. I'd say those are quite practical things that services can take and do.
And how, if you were chatting to your clinical colleagues saying that this is why it's worth you putting your discretionary effort into this, what would you say?
I would say, one, I think in the grand scheme of things, it does save time. I think it's, considering the systems that we use in it, I think using messaging platforms can be much quicker than using some of our current platforms we use to actually deliver our letters and send out letters. Then they could be easily copied again on the platforms to primary care at the same time as the patient. And I think it's even in systems where you don't have integration into to EHRs, it is simple ways of just copy and pasting and adding that data in. So I think all of these features can be enacted now. We already have a one-stop clinic where we have a nurse that requests all those tests, invites the patient for blood tests, has a scan on the day. We can potentially discharge 40% of people on the day from the first appointment. That's something we've already put in place. And then have virtual coming a bit to that tariff question, we have virtual slots in that clinic that are 5 minutes long. They're booked in. They have it's a follow-up appointment. It's logged, but that might take the form of a message or a 2-minute phone call, and it's relaying that bit of extra information back for those other 60% who don't go after the very first appointment.
Brilliant. Okay. All right. Thank you very much for joining us at lunchtime today. But from my perspective, I can see what's in it for the patient, I can see what's in it for the clinicians, I can see what's in it for the great British taxpayer, actually, in terms of how we break, which I think is the IHI triple aim. Thank you for joining us. Enjoy your lunch, and see you all soon, no doubt. Thank you.